Hello, everybody. I am Heather King. I am the Director of Education for Hope Abounds Cancer Network. I got to go around and, introduce myself to a few of you today. I really want to keep this as lively as possible with lots of participation. So I let most of you know there will be a session here that you're going to scan a QR code and we're going to participate in different things, but this is for each and every one of you. So I am a professor as well. So I do teach and I tell all of my students, I'm going to let all of you know, I know this information, guys. So this is for you to learn and grow from. So please interact with me as much as possible so that you get as much as you can out of it. So there is going to be an introduction on Hope Abounds Cancer Network, and Wes did a great job thanking our sponsors. Each and every one of you are growing every single day, and your roles, you're trying to figure out what you want to do and what the next step is. I'm hopeful that this is something that hopefully you can incorporate in whatever you do after you graduate, and or help yourself understand your family history or a family member or a best friend. So I'm very hopeful that you get something out of this today that you can apply to what you're doing. Myriad Genetics is here and they're our sponsors. They are a genetic testing lab. They also provided the breakfast and the lunch today. So thank you, Myriad. And then Novant Health is here. We're going to be hearing from Katie Griffin. She is a genetic counselor by training, and she's going to talk to you guys about that a little bit later. And then International Paper is another sponsor. So before we start, I'm going to bring up Miss Elizabeth Barnes. She is the executive director and co-founder of Hope Abounds Cancer Network, and she's just going to give you a little bit of history about how the organization came to be and anything else she wants to share. Come on up, Elizabeth.
Brief.
Okay.
Thank you, every one of you, for getting up early and being here today. This is going to impact your lives, and it's going to make a difference in your life and the lives of your family and your futures. Take it all to heart and be engaged. But the way Hope Abounds came to be, we are now celebrating 15 years. This year, we just completed a rebranding process. So we're proud to show off our new logo and all of our marketing materials. And so we have a table over here. You'll see Novant back here and then Myriad set up over here. And but I wish that my husband and I, when we received a phone call 15 years ago from our daughter, we had this information and that we knew the contacts. We did not know what to do when our daughter called home and said, "Mom, Dad, I've been diagnosed with breast cancer." She was very young. She was living in Atlanta, had graduated from college, gone down there on internship, and was staying and got diagnosed there at Emory Hospital, Atlanta, but came to Wilmington also. We got a second opinion here. And Kelly was at stage 0 breast cancer. But 3 weeks later, her surgery took place here in Wilmington where she decided to be treated. And her cancer in 3 weeks' time had mutated, which had grown to outside of the gland. It was contained within the gland. That's called ductal carcinoma in situ, stage 0. But it had broken loose. So she was at stage 3B in 3 weeks. So she had to be treated very aggressively, where we were only given 7 years. Okay. The doctors expected her to live. But praise God, 15 years later, she's still very much alive. A woman of great faith and strives every day to live the best life proactively and as her best health advocate that she can. And so we really recommend that for you. But we knew as a family when Kelly was diagnosed, we didn't know where to turn. We didn't know what to do. And this is why Hope Abounds, as a family, the three of us sat down and said, we need to make a difference. This happened in our lives for a reason, and it's to impact others. So the 3 pillars of Hope Abounds is to advocate for you as a patient or anyone in your family, educate you, and this is one of those opportunities now, and then do medical navigation, provide that service for you as well. And we could go more in depth into that if you want to come see us at our table, or you want to contact me. I'd be happy to do a Zoom call with you, or answer whatever questions that you have. But most of all, I just want to say too that you can be the generation of change. You can be the voice of, we can't eradicate cancer, but we certainly can, by this knowledge of what you have here, you can be impacted by having a very positive attitude, making the right decisions, sharing it with your family. And it's not something to be afraid of. It's something to really take to heart and not live in fear. You know, if you have cancer in your family, be proactive and live the best life you can. So take this and this knowledge that you're going to be empowered with. And then I also want to share that, you know, we really would love to have collaboration. If any of the fraternities here on campus, or sororities or clubs, we would love to be considered as a charity platform for one of you. And we want to be able to do good work. And we thank you to the College of Health and Human Services. Thank you. And to all the staff, and Wes, you've been wonderful. And Heather, take it away.
Okay, perfect. We have some UNCW interns that are here today.
Thank you.
You're welcome. Do you want to stand? Perfect. Wonderful. It's great. Do we have more interns here?
They're
coming. Okay.
Yeah, they're
more coming. So we do partner with UNCW, and we're grateful for that partnership in lots of ways. So, okay, before we get started, if I raise a hand, who has either personally been impacted by cancer with a personal diagnosis, family member, or friend? Okay, look around the room, guys. Unfortunately, we all know cancer, right? So this today, some of the statistics that I might share with you might be a little scary. It's all about perspective. So once you get diagnosed with cancer, it is no longer your timeline. The doctors tell you where to go, when to be there, and all of the steps. Understanding some of this can hopefully help you be proactive. And it's your timeline. You get to make the decisions. You get to make the choices that impact your future and what that timeline looks like. So this is meant to be educational. Knowledge is power. I'll say that over and over and over again. So there are going to be some statistics, but just understand that you can either put your head in the sand or you can understand. Either way, outcomes are the exact same, right? But you get to dictate and determine how your path looks by understanding this information. So, okay, everybody get out your phone. I think this works. Okay, scan the QR code. QR code is not working for you. You can also put in the session ID. They good?
Not yet.
Not yet. I'm doing 2 phones.
Good?
Yeah.
Okay.
Use my phone and go
Okay. Okay. What is my knowledge level of cancer genetics? Limited or basic understanding, moderate understanding, extensive knowledge, or what presentation did I accidentally walk into this morning?
I'm not seeing any options. Is anyone else having trouble? They
All
don't
I
see any
see
options.
Oh, okay.
There's ask a question.
Oh,
Makes me so sad. Okay, do you want us to hold up numbers on our fingers? Oh, this makes me so sad. I love it when technology works. Okay. By raise of hands, who says A, limited understanding? Okay, B. I like it. Okay, C. D. Oh, I love it when technology works and sometimes it doesn't. Okay, so most of us were A or B. We have some understanding or a moderate understanding. The goal today is just to continue that and move that forward in whatever way possible. Hopefully you'll get that from me, you'll get that from Katie, and then we also have experts that are here as well later. So, okay. What does an airplane have to do with anything? Who went anywhere and flew anywhere on spring break? Anyone? Okay, few of you. Anybody have any fun summer trips planned where you're gonna fly anywhere? Okay, so I took a plane to get here today and we'll leave later this evening. What if, as you are getting ready to scan your ticket and walk down the runway, somebody came across the speaker and said, there's a 50% chance that by the time you reach your destination, the plane will get there. 50%. So 50% chance it'll crash. Who's gonna get on that plane? Yeah, none of us? I know, that's a really not great statistic, right? Now, what if you were told there's an 87% chance that there was no way you were gonna get to your destination? Definitely wouldn't, right? Those are the numbers when someone has a BRCA mutation. So within their lifetime, there's an 87% chance that they'll develop breast cancer and a 50% chance that they'll develop ovarian cancer. So understanding that you have a genetic mutation, it is completely different, right, than if you're general population risk. And we'll talk about general population versus others, but those are the numbers. So when people look at individuals that make what is considered aggressive choices, it's the same thing getting on the plane. You have that ability. You're like, nope, I'm not walking onto that plane. Because nobody wants a 50% chance of making it to their destination or 87% chance if you know that in advance. That's why you get genetic testing done, so that you know that if you're appropriate. Like I said, some of the numbers are a little scary, but so within a lifetime, all the men that are in here, there's a 1 in 2 chance that you're going to develop cancer. For all the women, there's a 1 in 3 chance. If we are lucky and live a long and happy and productive life, right? Of those people who have a cancer, 1 out of 8 have a genetic mutation. If you don't know, then it's not going to help future generations, your treatment. This says that 1/3 of patients with high-risk mutations can benefit from different targeted therapies. So knowing this information doesn't just change your screening, it doesn't just change some surgeries that you can decide to get, but it also changes the therapies that your oncologist could give you. So understanding this really is important in making impactful changes for your future. Okay, who knows who this woman is? Anyone? Anyone want to say?
Beyonce.
Beyonce, that is correct. So I have a few different people in here and I have 3 girls. You guys will see a picture. They're 14, 16, and 18. And my daughters told me the other person, no one knows who it is, but that they know who this is. So, so y'all know who Beyonce is. So anybody know who that gentleman is beside her? That's her dad. Her father had male breast cancer. Where, right? He was tested, he has a BRCA2 mutation. So then both daughters were tested. They were both negative. So these mutations, most of them are autosomal dominant. So if I would have it, my kids would have a 50% chance. And we'll go through some of the genetics 101.
But because Beyonce and her sister both tested negative, they're back to general population risk. So they're back to that normal, you know, what all of us that don't carry a mutation would get. So that knowledge is so empowering and so impactful by knowing it. And because her dad was tested and knew he had a BRCA2 mutation, that specific mutation was what Beyonce and her sister were tested for. So that goes back to a true negative. So back to general population risk. So the same as if you didn't carry a mutation. Okay, who knows who this lady is? Okay, see, my kids were wrong. I'm like, she's not that old. Come on, y'all. So everyone knows Angelina Jolie. Does anybody know what she did?
She's an actress.
She what?
She's an actress.
She's an actress, but what did she do?
She's a previvor, right?
She
Previvor.
is. She's a previvor, which is great. So she knows she carries a mutation. And so before she had cancer, she decided to get some surgeries done. So her family history was crazy. Her mom had breast cancer and then died of ovarian cancer. Her grandmother passed away from ovarian cancer. Her aunt ended up passing away after she had her surgeries done. So she had a prophylactic mastectomy. So she had both of her breasts removed. And then she also had an oophorectomy. She had her ovaries removed because it goes back to the numbers that I told you at the beginning. That 87% chance of developing breast cancer and 50% chance of developing ovarian cancer. And she saw all of these women around her passing away that she loved. And I don't even know if anybody know how many kids she has. I don't even know how many kids she has. She's adopted a whole bunch of them, but she wanted to be there to see them live, graduate from high school, graduate from college, get married. You know, she's doing all of her humanitarian work. So some people can say that it's drastic, but it goes back to that, would you get on the plane? Most of us would say no. She decided to not get on the plane. She decided to take actions, to be proactive, and that was her choice. You don't have to do that. You can get increased surveillance, you can get mammograms and MRIs. You know, there's so much that can be done if you know, and insurance will cover most of those proactive testing procedures. Any questions thus far? Okay. So Miss Katie, the genetic counselor, is going to go into all of this, but this is my family history. This is why I got into this. So there's me, little circle towards the bottom. I have a sister. If you go up, you can see that there's cancer on both sides of my family. So my dad's side of the family, my grandmother, great grandmother, both passed away from ovarian cancer. My mom's side of the family, I had an aunt with breast cancer. I had an uncle with prostate cancer. We're going to get into syndromes and how it all is related. I had a maternal grandmother with breast cancer twice, once in her 50s, once in her 70s. And then there's some other cancers that are in there, esophageal cancer, and then a great grandmother in her 70s that had cancer. So I actually didn't know this because even though our family talks a lot and we're all kind of chatty, sometimes people don't like to talk about cancer or why people passed away. Like I knew about my maternal side, but I knew nothing about my paternal side until I really started asking questions because they passed away before I was even around. So understanding and asking questions is essential to really empowering yourself to know whether genetic testing is right for you and how that plays a role in everything. We are going to go through a cancer family history tool. Okay, here's your genetics 101. Just taking genetics 101. This is always fun stuff. So we have mom and dad at the top, right? And if there is something like a BRCA mutation, so in this one, it's affected father. So it's like Beyonce's dad, right? Mom was negative, dad was positive. 50% chance that you're going to get a mutation.
some of the percentages that we talked about before, those are on the left-hand side. So it's a coin toss. Obviously, as a parent, you don't want to give your kid an affected, or a genetic mutation that you're passing on, but oftentimes you don't even know. So it's important to know as soon as possible, even before you have kids. Because if you do something like this before you have kids, there's a lot out there. There's actually a patient speaker that we have who knows she carries a BRCA mutation. Her mom carries a BRCA mutation. Her brother carries a BRCA mutation. But before she had children, she actually ensured that the embryos that they were reimplanting into her did not carry the mutation. So she stopped the cycle. So there's a lot that can be done to ensure that you're not passing that mutation along. Okay, so hereditary breast and ovarian cancer syndrome. It's breast, ovarian, pancreatic, and prostate as of right now. Those are the 4 within the syndromes. You can see the little family history up there at the top, and then cancer in both of one organ. So that would be 2 primary. So say somebody had breast cancer in their left breast and right breast. Family member with a sex atypical with a cancer atypical for their sex, that'd be like male breast cancer. Not normal, right? Like Beyonce stuff. More than one relative with the same type of cancer. You saw that in my family history, or family members with multiple cancers. So these are all red flags. And fortunately or unfortunately, a lot of healthcare providers have not been trained in genetics. And so this is why we're empowering each of you to understand this and go there with a family history tool, potentially a kit, and be able to say, this is what I want, this is what I need. And if they won't do it, then you find Katie here that will do it for you. Okay, my tool's not working still, but okay. Which of these is correct? I can shout it out. B is correct. So even though it doesn't seem natural to group certain cancers together, hereditary breast and ovarian cancer syndrome is breast, ovarian, pancreatic, and prostate. You're going to see an overlap with some of these. The prostate cancer is normally a more aggressive prostate cancer. And when they're looking at things, there's a Gleason score. The Gleason score is normally higher as well. So these are just things when you start looking at your family history, trying to think like, okay, there's some component that kind of matches all of this up. Okay, Lynch syndrome. Lynch syndrome is just as prevalent as hereditary breast and ovarian cancer syndrome, but there are 10 cancers within this. So colon, endometrial, gastric, ovarian, ureterorenal pelvis, biliary tract, small bowel, pancreatic, sebaceous adenoma, glioblastomas. So 10 cancers. I always say that when doctors figure out that it's Lynch, those are really smart doctors. Normally, I think the statistic is patients aren't diagnosed with Lynch until their 3rd cancer. Their 3rd cancer, guys. So, and it makes sense to a certain extent because if you're in, here's for example, I went in to get a mammogram. They only asked me about my maternal side of the family and if my mom or sister had breast cancer. That's it. That's what they asked me, right? So it's important to understand these syndromes and why they go together. If someone's going to get a colonoscopy, they're probably not going to think, oh, well, somebody had breast cancer in my family or somebody had ovarian cancer in my family, They don't understand how these syndromes go together. So that's why this information is so important. You don't want to be the one that, your family member or you is finally diagnosed with something on their 3rd cancer. That's just a lot. So I personally, there's no poster person for Lynch. There's no Angelina Jolie for Lynch right now that we're aware of, right? But personally, like, this is one that have always been super passionate about, even though it's not the one that's like kind of in my family, because people are so impacted by this. And so this is one that I'm like, okay, look at it, see 10 cancers, not necessarily all related, but really important to understand and know. Okay, how many cancers are in Lynch? 10.
Yeah.
Awesome. Yep. And how many are in HBOC, hereditary breast and ovarian? 4. Yep. So both just as prevalent. Okay, who needs genetic testing? So there are a ton of guidelines that are out there. There are all these different societies: National Comprehensive Cancer Network, American Society of Breast Surgeons, American Society of Clinical Oncologists. Everybody has guidelines. The guidelines kind of dictate insurance coverage, right? So what they say is young, multiple, rare. Young cancers, for all of us that aren't students in here right now, 60 and under with certain features is considered young. So all of us are really young in here, right? Multiple cancers, it's like I showed you with some of the slides. Multiple cancers in the same person, in the same family, that's important to know. And then rare cancers, male breast cancer, ovarian cancer, both very, very rare. So when we're going through the family history tool, just think young, multiple, rare. So, you know, I had an aunt with breast cancer in her 40s, so young. And, you know, Kelly
32.
was 32 when she got diagnosed. That's why Hope Abounds is here, right? So it happens, and it's just important to know and empower ourselves. So ask questions. Our family tree is so important. If we're adopted, we might not know these answers. If we have a estranged family, we might not know these answers, but ask as many questions as you can to truly know. So 3 generations matter. So unlike when I went in for my mammogram and they only asked me about my mom and my sister, maternal and paternal matter. Both do. Just like Beyonce's family. Her dad is the one that carried the mutation. The young lady that I told you about that had the embryos that were pre-implanted without the genetic mutation, it came from the father's side of the family, and he had never had cancer. So it's just that the women above him did. So it's just important to know all of that. So 3 generations is great grandma, great grandpa, cousins. So all of that matters, and it really does make a difference. So understanding all of that is really important. Okay, how many generations? 3. Awesome. I hate it, this tool is not working. Boom. Okay, as Elizabeth said at the beginning, we need to advocate for ourselves. Unfortunately, when you go into the doctor, they have, I don't know, 3 minutes, 5 minutes, 7 minutes, 10 minutes. And you might talk about every single thing in the world that's going on right now. You know, you might have, you know, toenail fungus and your throat hurts and, you know, you have an ache in your back. And, oh, by the way, I have a ton of cancer in my family, right? So you have to advocate for yourself. Each of you know your body best. You know what's going on with you. If something doesn't feel right, something doesn't look right, and somebody brushes you off, see somebody else. Like I hear it over and over and over again, where they'll go to a doctor and the doctor's like, it's nothing, don't worry about it, seek a second opinion. So you have to do everything you can to be your best advocate. You need to be heard. You have to be heard, because if you're not going to be the one that's advocating for yourself or a loved one, then nobody will, right? And like it or not, every single doctor, they go home and they go to bed at night and they put their head on their pillow and they're good to go, right? So they do the best they can while they're with you during that time, but you have to advocate for yourself and take ownership of your health. So big questions, how do I get genetic testing done? I'm not a big fan of getting my blood drawn, but that's an option. And then a saliva sample, so you can spit a tube. So we do have some myriad kits that are here today. All this does have to be ordered by a physician or someone, a nurse practitioner, PA, genetic counselor, it's super important to understand that you need to have a proper informed consent. You need to understand all the details associated with genetic testing. Katie's going to go through some of those details because it does affect things like life insurance and some other things. But it's super easy to get this done. So either a blood draw or saliva sample. So I told you I'd show you my girls. These are my girls. I have 3, 14, 16, 18. And, you know, as you guys get through life, like when I graduated from college, it's like, I'm going to be CEO of whatever company I work for. And, you know, and that was at that time, that was my why. So your life will keep changing and evolving, and things you want and things you need and things you do, that'll keep changing in your body. So your who or your why and why you want to live and what you're doing. I want to be here to see these guys graduate from college and to get married, and if that's what they choose to do, right? And whatever that path looks like. So I want to be here as long as possible. So understanding and knowing your genetic risks, it does impact how long you're here. You know, nobody knows when God's going to take us off this earth, but I'm going to do everything I can to be here as long as possible. Okay. Once again, I wish this worked. I'm going to ask you guys just to kind of raise your hands by, just as an overall, do you feel like you better understand cancer genetics today? So anybody feel like they learned something? Katie didn't learn anything. She knows everything. Okay, so what questions do you guys have for me? Is that good? Yes.
What are the implications for your daughters? If I probably missed that part.
Yeah, so say I tested positive, my girls would have a 50% chance of inheriting the mutation, and I would want them to get tested. Everything says they should get tested when they're old enough to actually, it depends on the mutation. So if it was something like a colon diagnosis where they form lots of polyps, some of those kids need tested really, really early. Really early, like 6, 7, 8, because they form so many polyps in their colon. But say it was a BRCA mutation. Once they're old enough to understand the implications, they say 18 probably, or 10 years before the first cancer. So they should get tested, and then they can make decisions based on that, whether it's freezing eggs or, you know, getting increased surveillance with mammograms. Okay. So it changes how they're going to live and what they're going to do. Yeah, great question. Yes.
Any thoughts on colon cancer? I feel like that's like it has changed from being like an old person's cancer to like, I know somebody in the early 40s who was diagnosed recently. And then she kind of opened my eyes to a lot of people that are diagnosed younger and younger. And they don't recommend being screened for it until you're 50 now. I think they moved the.
Did it just change?
It did. So it is 45
Okay.
now, but we are consistently seeing younger and younger ages of diagnosis. So I imagine screening will continue to move up, and I wouldn't be surprised if it's 40 in the next couple of years. I don't know if you want to add anything.
Yeah, you know, all cancers unfortunately are getting diagnosed earlier and earlier. And you know, with cancer genetics, and I really didn't go into it, they kind of call it the 2-hit hypothesis. So if you say I'm negative, by the way, even though my family history is kind of chaotic. So say that I did have a BRCA mutation, every single cell in my body would have 1 hit. So, and you're born with 1 hit. Now that doesn't mean that every cell in my body is going to develop cancer. It's just those cancers within that syndrome, there's an increased risk. We're all breathing the same air, drinking the same water, which she knows what's in that, eating the same foods. And so that second hit happens quicker. And that's why it's younger cancers, because you're kind of predisposed. You have one hit already. Normal, you know, when I told you in the beginning that normal cancer risk, all of us are still eating the same food and drinking the same water and exposed to the same radiation. So cancer does happen, like our cells just kind of break down, and those mechanisms that keep them safe and healthy just kind of change over time. But it is happening earlier and earlier. And so just empowering yourself and understanding is really important. But yes, you're, you know, and we're all getting older every day, right? Which is better than the alternative. That would mean we're dead. But you're going to see that you guys are going to see your parents, grandparents, people in this room, you know, getting sick. And it's just part of getting older, guys. But just trying to be as proactive as possible. And nobody wants to get a colonoscopy. Get a colonoscopy. Who cares? You know, people talk about getting their boobs squished, getting a mammogram. Who cares? You know, I mean, these are just things that getting older that you're going to talk about more and more, and you're going to do more and more. And that's just the normal part of aging. It's fabulous. So, yeah. Yes.
The 3 generations that she's talking about too, it goes to your siblings, your cousins, all the way out, 3 generations on both sides of the family. Our daughter Kelly had a papilloma around the age of 30. Papilloma is a calcified milk gland in the breast. We went to Atlanta and had that removed. She was a school teacher in Atlanta. We asked the doctor, is there any concern? And then a few years later, Kelly found another knot in her breast. So she went back to the doctor, and the doctor said, don't worry about it, it's just scar tissue. Well, she was in the school system and they changed insurance providers. So she went to find another doctor. That doctor was much more proactive, like all of us need to be. They said, before you leave today, we're going to do a mammogram. We're going to do an ultrasound. As a matter of fact, we're going to do a biopsy. And it was cancer. Her mother and I cried more than she did, but she's just that way. She just is very positive. But again, it's being proactive. It's up to you. It's up to your family member. You're the one who has to be the proactive one.
Thank you, Kenny. Yeah, it's very important that you continue to empower yourself and just make sure that you're asking the right questions to your family. You're taking charge of your own health, even if the healthcare provider pushes you off, because this information is really important. Okay, that's it for me. I'm gonna turn it over to Katie Griffin. She is, we have not had a genetic counselor, a certified genetic counselor in our area for forever. So I'm really excited to have her here, and she's gonna go through what she does. So.
I think we did have some time built into our agenda for a bathroom break. So if anybody wanted to use the restroom or get some more food, I think we have some more over there, get a coffee, refresh, please feel free to do that.
You guys want to take just a quick 5-minute break?
Take a 7th inning stretch. Like Heather has said, my name is Katie Griffin. I'm a cancer genetic counselor and I work at Navant Health in the Zimmer Cancer Center. So my job here today is gonna be to talk about how I got here, what genetic counseling is, because I think that sometimes is an unfamiliar term for folks or an unfamiliar profession. I'm gonna talk about my background experience, and then I'm gonna talk about what it's like in a cancer genetic counseling session. So you all know what you or your family members could be getting into if you think that cancer genetic counseling or testing could be right for you or them. So I'm gonna first just read you this quote. What does a genetic counselor do? So genetic counselors have advanced training in medical genetics and counseling to guide and support patients seeking more information about how inherited diseases and conditions might affect them or their families, and to interpret genetic test results based on personal and family history. So to paraphrase that, I would say that I work with patients either to help them understand their genetic condition or their genetic risks. And then I talk about how that not only impacts them, but their family members as well, because we know that unavoidably genetics is a family business, sometimes for better and sometimes for worse. But that is my job. So how did I end up here? I did my undergrad at UCLA and I graduated there in 2019. I majored in biochemistry and minored in classical civilizations. And when I started, I had not really a good idea what I wanted to do with my career. I think that's a lot of our experiences probably. I started thinking maybe I was gonna go into forensic science. I'd always liked science. Shout out to anyone who's ever seen NCIS. That was my show growing up. I thought that I could work in a crime lab. That would be so cool. And I did a forensic science internship and decided I could not work in a lab for the rest of my life. So that was very fun. I also, probably like a lot of folks majoring in one of the physical or life sciences, thought maybe I could go to medical school. But then I had a dissection in an anatomy lab and I thought, no, never again. People's insides can stay on the inside. I don't want to see them. I don't want to touch them. So that was not for me. So then it was back to the drawing board of, okay, I like science and I know I like working with people. I was an academic peer counselor in college as well. So I worked with students to help them understand academic policies better. We figured out what classes they should take or whether they should add or drop a class, things like that. So I knew I liked both those things. And then I went to my one and only event hosted by the Career Center, which just so happened to be, I think, in March of my senior year. So it was getting down to the wire, down to graduation. I still had no idea what I was going to do. And they had brought a bunch of different genetic counselors representing different specialties. And I thought this was perfect. This was the perfect combination of science and working with people, and I could do this. But then I realized that, well, it's my senior year, I'm graduating, and I don't have all the requirements that I need to apply to programs. So I did take a couple of gap years. I have posted on the right-hand side of the screen, you can see, I don't know if this is gonna work. These are the application requirements specifically for the program that I went to. And it's a combination of coursework, so some kind of biology, chemistry, and then some kind of social science like psychology oftentimes. And what they also recommend, these genetic counseling programs, is that you have some research or lab experience, which I didn't have, some kind of crisis counseling experience, which I also didn't have, but at least I had some counseling experience, and then some volunteer work. So I knew I needed to put some work into my application. So right out of college, I worked as a lab tech in a gene sequencing lab, which I thought was perfect. I could get a little bit of the behind the scenes sort of information and context for what I'm doing now. So I worked there for about a year. And then I had an opportunity to work at a different company in a DNA extraction lab. And that lab was more in line with commercial genetic testing that I'm doing. So I got to work with some of the genetic counselors that work there, and I got to shadow a couple of them and figure out and make sure that this is something that I actually did want to do. And that was, I was only there for 5 months. And then the first company that I worked at said, hey, we want you to come back. We have a new position as a project specialist for testing that they were doing related to COVID. Different pharmaceutical companies were using this particular test to figure out, were their vaccines working correctly that they were trying to put through clinical trials, and were these different COVID therapies working well? So I came into this role at a company that I knew, and I knew the people, but I had no idea what this testing was. I barely knew what COVID was at that point. So that is all to say that I had 3 different jobs in 2 years. The longest one I held was for a year. So I think we really emphasize right out of a degree, you have to have your first job for 2 years, or people gonna think that you can't hold a job or whatever it is. I think that experience is meaningful if you want it to be, and if you put in that work. And I think I got a lot of transferable skills out of that last position that I really enjoyed. And I also volunteered at a cat shelter in that time until COVID hit, which I talked about actually during my grad school interviews. And they appreciated that I did volunteering in an area that I enjoyed and I also got meaning out of. So my last professional position and my volunteer work wasn't really related to genetics or genetic counseling, but it still served me well, and I'm glad that I did all of that. Then I got my master's at UNC Greensboro. So that is how I ended up here in North Carolina. I moved out here for my master's, and I graduated there in May of 2023. So I'm just under a year out. There are about 50-ish genetic counseling programs across the country, and most of them are 2 or so years, and they combine didactic coursework and lectures with clinical experience or rotation. So I did a total of 5 clinical rotations, and I got to see a ped specialty, prenatal, and of course cancer. And I also did a lab specialty. So I got to work in different clinics in North Carolina and start growing my network while I was in school, and also figure out what it was that I wanted to specialize in for genetic counseling. There's also a research requirement for programs. So I did a capstone project, and then we also had some advocacy and community engagement work. So I got to work with some local folks in Greensboro who have genetic disorders. That was very cool. And then I'm here, like I said, at the Navant Health Zimmer Cancer Center. That is our center on the left. And then on the right, that is all my coworkers going out to a Hope Abounds event. So it has really been a lovely opportunity. I am the first cancer genetic counselor in Wilmington. So that is exciting and intimidating all at the same time. But it is great to be working with Hope Abounds and get to come out to community events like this and get to chat with people about what genetic counseling is and what genetic testing is and why it's important. So that's all my experience. Before I jump into what a cancer genetic counseling session is like, any questions about my experience or what the job is like? Yeah.
What did you get your master's in?
It's specifically in genetic counseling. Yep. So the 50 programs I mentioned are all specifically accredited in genetic counseling. Once you graduate from that program, you're eligible to take our boards exam, which I took back in September. And so now I'm board certified. Any other questions I can answer at this point? Yes.
How, on average, how much is it to take the master's program, if you don't mind me asking?
Oh,
Across the country.
it varies. UNCG, I think, is the cheapest in-state program. And then, of course, like programs like Columbia are probably the most expensive. I think it was 13,000 per year. So it's expensive, definitely, but I think Columbia is like 85,000 a year. It's crazy. It's the same degree, so I figured might as well get it for a little bit cheaper. Any other questions? Okay, so let's talk about a cancer genetic counseling session. Typically, I'm seeing patients in one of 2 ways or in one of 2 stages. So either I'm seeing them to evaluate them for pre-test counseling before they've had genetic testing. Do they qualify for testing? Is it something that they're interested in? Or I'm seeing patients after they've already had testing and talking about how that's going to impact them and their families. So to break these down, pre-test counseling, I'm always getting a patient's personal medical history. So have they had cancer? How old were they when they were diagnosed? When was their last mammogram? When was their last colonoscopy? Have they had any other sort of benign tumors? I'm making sure that I'm keeping an eye on everything, not necessarily just what's malignant. And then I'm getting their family history, and I have a slide on this that will talk more about what exactly I'm looking for in a family history. So I'm going to put a pin in that. I'll do a risk assessment. So I'll put together a patient's personal medical history and their family history to say, do they meet genetic testing criteria? And what's sort of the likelihood that they test positive? Is there a high risk here? Is there a low risk? And then we talk about test options. We have different panels of different genes sometimes at some companies, and they're organized by the type of cancer. So like, for example, we have a breast cancer panel that's about 13 genes. And we have a colon cancer panel that's about 20 genes with some overlap in between, and all other different kinds of panels. I'll do informed consent. So I'll make sure that patients understand the risks, the benefits, and the limitations of testing. And I'll talk more about what goes into that on another slide. And then I'll help them come to a decision about testing. Like I said, not every patient is ready to do testing right when they walk in the door. Knowing that the plane has an 87% chance of not landing, some people aren't ready for that information, and I think that's okay. And I'm there to give them that choice. I'm also helping them decide sometimes between different sizes of testing. So sometimes we focus on the breast cancer panel, that's 13 genes, or I say we can test for 70 different genes all related to hereditary cancer. It just depends on how much information, how much uncertainty are you comfortable with, how much are you comfortable with the idea of getting some unexpected information, things like that. If a patient has already had testing and I'm seeing them for post-test counseling, then I may be getting their personal medical history and family history if I haven't seen them before. And then again, I'm explaining how their results impact both them and their family members. So we'll go through some of these bullet points in more detail, but if a patient's testing is negative, how reassured are we? Sometimes there's a lot of cancer in a family, and if someone tests negative, does that mean that their family members are off the hook? Does that mean that they're not at risk for cancer? So we'll talk about that. Like I said, sometimes we get uncertain information with genetic testing, which I'm sure is not a surprise to anybody. With all tests, there's always kind of these borderline results. But what an uncertain result means is that we've taken someone's DNA and looked at their code and we've compared it to a reference. And there's some change there, but we just don't have enough information to interpret what that means. It could be that it's associated with an increased risk of cancer, or it could be totally normal variation in the population. We all have 20,000-ish different genes, and some of them are spelled a little bit differently, and it doesn't necessarily mean anything bad. But that's something that we talk about sometimes on the upfront of testing, just so that people are prepared to have that kind of information. And then of course, if a patient is positive, what's the best follow-up? Like Heather was saying earlier, we have all different kinds of societies that give us different recommendations. So we'll go through whatever the risks are that are associated, and then whatever the management recommendations are. That was a lot of information again that I just threw at you in one slide. Any questions about any of that or any of those components? Yeah.
So I'm interested in, with the post-test, say you're positive, and the best follow-up, we're all a bunch of social workers in this group. So
Okay.
I'm wondering that next step of, okay, I'm deciding to have my ovarian, ovaries removed or a full hysterectomy, it's gonna put me into menopause. Who's the person that works with the patient then? Like as in a counseling arena?
So I would send them first to a gynecologic oncologist to say, let's go have the conversation about screening. Getting some feedback. All good. So I'm gonna refer them to a gyn-onc specialist, and they can give the patient more information about, like, some of the benefit numbers, the data around screening and how effective it is, and then what does surgery mean for them? Is it gonna put them into an early menopause, and how are we gonna weigh putting them into an early menopause at 35 years old and the consequences that might have for bone and heart health with the risk of ovarian cancer? So that's something I always talk about up front on my counseling end, but then something that I know they're gonna need more information from a specialist. And then often I am saying mental health services should be involved. We don't have a specific.
And that's what I was
person in
wondering, where's the
community.
mental health piece
Yeah.
of it? Okay.
Yeah, there is not. So a lot of patients will tell me like, I'm already in therapy, and I'll say like, bring this up to your therapist, good to talk through, but I don't have anyone specifically. If y'all know of anybody in the community,
I just wasn't sure, you know, if there was that next step of the partnership between the oncologist and a therapist, you know,
Yeah.
in the hospital
Yeah.
for post.
Not established
that care.
yet, unfortunately. We do have some social workers within Zimmer, but they're more for patients with active cancer, so I can't even refer it.
I was just curious.
Yeah.
Okay.
Any other questions based off this slide? Okay. So this is sort of a general diagram of a pedigree. You saw Heather's earlier. To break it down even further, the squares on here represent males and circles represent females. We are always trying to be as gender inclusive as we can. So if I'm seeing a non-binary patient, or if someone has a non-binary person in their family, I'm representing them with a diamond. And if someone is transgender, I'm representing them with a symbol that best represents how they want to identify. And then I might be writing assigned male or female at birth next to their symbol. When it comes to cancer risks and the types of organs that people have, sometimes that's important information to have documented. But I think this is generally pretty self-explanatory, hopefully. So we can see on different lines, different generations. Let's see. Change this to a laser pointer. So you can see my cursor. Okay, so this obviously is parents to a child. Parents to a child. These people are married, these people are siblings, so on and so forth. When I'm taking a family history specifically in the cancer setting, I want to know who in the family has had cancer, how old were they when they were diagnosed. I also want to know generally how old were people in the family when they passed away. Are people passing away really early, like in their 20s, 30s, and 40s, and may not have made it to an age where we typically see cancer develop? I'm also asking about ancestry or countries of origin. We know that there are certain populations where certain genetic mutations or variants are more common. So for example, the Ashkenazi Jewish population. If anybody has heard of a connection between the BRCA genes and the Ashkenazi Jewish population, we know that about 1 in 40 people of Ashkenazi Jewish descent have a mutation in one of the BRCA genes. So if I'm seeing someone who's Ashkenazi Jewish, right off the bat, they have about a 2.5% chance to test positive for one of those genes. And I'm also asking people if their parents or their family members are related. If I know that both mom and dad's side share the same genetics, I might be evaluating that slightly differently. Okay, so here's our slide about informed consent, which I already started talking about. Like I said before, this is where we talk about risks, benefits, and limitations of genetic testing. So first, I'm talking about the types of results that we can get. And again, that would be positive, negative, and uncertain. And I'm trying to understand how a patient would feel if they got any of those results because I want to know, are they ready for this information potentially? And then I'm trying to give them examples of how a positive result might impact their life. So we might be talking about, you might learn that you have up to an 87% chance to get breast cancer. And if we find that to be true for you, then we're going to start talking about more screening and mammograms and breast MRIs. And we're going to throw out the possibility of doing surgery. So just to know, those options might be on the table. If we're talking about Lynch syndrome or increased risk of colon cancer, we're talking about getting a colonoscopy potentially every 1 to 2 years, and then doing an upper endoscopy every 2 to 4 years. So those are different examples of how what the risks might be and how management might impact somebody's life. Testing is never perfect. There's always technological limitations. So we're talking about the fact that just because someone's testing is negative, it's not perfect. It doesn't necessarily completely rule out the idea that they have some kind of genetic mutation. But certainly our technology has gotten much better over the last couple decades. We're also talking about insurance implications. I don't know if anyone has ever heard this before, but sometimes people talk about how genetic testing can sometimes impact life insurance or the ability to get life insurance. So we have this law called GINA, and that stands for the Genetic Information Non-Discrimination Act. What that means is that we are protected in terms of how genetic testing information can be used against us. That's true for healthcare insurance. So you can't be dropped from your typical healthcare insurance. They can't raise your rates or anything like that. You're also protected in employment settings, so you can't be fired for your genetic test results. But the same protection doesn't extend to things like life insurance, long-term care coverage, or disability insurance. So what that means is potentially if you go to take out one of those policies or you go to make a big change to an existing policy, they could ask you, have you ever had any genetic testing? And you'd be required to answer honestly, and you might be asked to give them your test results. And they could use that to say, we're not going to give you this policy, or your rate could be higher than it otherwise would. This is not me saying that it necessarily is likely if someone tests positive for a hereditary cancer mutation that it would be used against them. But this is to say that it could. And so I always bring this up on the pre-test side, because some patients do want to get life insurance in place before doing this kind of testing, particularly if they already know that they have some sort of mutation running in the family, and it might be up to 25% chance or 50% chance for them to test positive. Some folks also want to know about data privacy. I think particularly recently, we've been hearing lots of stories about genetic testing companies selling data to the government or different companies, or this being used for like law enforcement purposes. So I always hand patients the informed consent document that comes from whatever lab I'm using, and they outline the data privacy policies there. But if they have any questions, I'm happy to always reach out to the lab and find out more information for them. And like I said earlier, my job is to give patients all this information and help them make a decision about testing that's right for them. And sometimes that choice is that they're not ready for that information and they want to come back and think about it later. We might be weighing, the patient doesn't want this information for themselves, but they really want it for their family members. And so how do we reconcile that? And do we need to get their kids on the phone, and do we need to loop them in, or do we need to loop in a partner so we can lean on somebody? And I will also say that we like to start genetic testing with somebody in the family who's already been diagnosed with cancer themselves. I want to know, does this person have a mutation that explains their history of cancer that we can then look for in their family members? Like if we take the Beyonce example, if testing had started with Beyonce and she was negative and her dad never had testing, then we're left in this boat of like, was there something there that we didn't find? So always, generally, if they're available, we want to start with the person with cancer. Sometimes that's not available and we do the best that we can. Questions about any of this information?
With the insurance.
Yeah.
Is it, like, I know life insurance, say you have it and then something happens, you can kind of get away with not reporting that to like mess with your rates and stuff. With like disability, when you're going into that, is it like retroactive in any way? Like, are you required to, say you have your policies, is there any way that you would like have to then say, oh, then I got testing?
Only if you were making a big change to that policy and for some reason you had to fill out more like demographic type info that they could ask, but it's not like if you already have that policy and you learn it, you're not required to report it. Yeah.
Thank you.
Other questions about this? Yeah.
Do you ever get like a false positive on any test, or is that just not that common?
It's a good question. So sometimes we get funky results, particularly in patients who are older and or they've had chemotherapy or radiation in the past. Sometimes we see maybe artifacts from that. Are the cells that make the blood cells in our body, sometimes they will get a mutation in there. And then some of our blood cells have that mutation where the rest of the tissue in our body doesn't. So sometimes if we get that kind of result, I'll say we can clarify this by getting a skin sample. Sometimes patients want to do that. It depends on how that might impact them to actually confirm the result or not. That's the only time I've seen really like a false positive happen. There are always sample swaps in a lab. I've worked in a lab before. I know it happens, but otherwise I think generally the odds of a false positive or being some sort of artifact unrelated to what I've said is very low.
Katie, can you elaborate on like a 23andMe doing a BRCA
Sure.
test versus actually doing it from a clinical lab?
Yes. So if anyone's ever done 23andMe before, has anybody? Raise their hands. Okay. So you might be somewhat familiar. 23andMe does look at the BRCA genes, BRCA1 and 2. What they do is they're looking for the 3 most common variants in the population, and we call these the founder variants in the Ashkenazi Jewish population. So that's what I was mentioning earlier. That's sort of more common mutation found in the Ashkenazi Jewish population. They're only looking for those 3. So if you get a positive, it's pretty good that you're positive for one of the 3. If you're negative on 23andMe, that's good news. You don't have one of the 3, but we haven't looked at the rest of the BRCA1 and 2 genes. So we could be missing a lot of information. I would not take a negative from a 23andMe and be like, we're good to go. My risk of breast cancer is low or average. Compared to clinical testing that I'm ordering, we're trying to get the most information in the gene that we can. Like I said, there are always limitations. Some genes are harder to look at than others, but that's the main difference between clinical testing and what's more commercially available. Other questions that we can think of now? Okay. I'm going to go through a few different patient examples. So I'm going to show you their pedigree that I took in clinic. I'll tell you how I evaluated their pedigree, and then I'll tell you about the results and what that kind of meant for them and their family members. So this was a 66-year-old coming in. She was diagnosed with breast cancer. So let's see. The arrow is pointing to her. Let's see if I can get on this side. Right there. I should really put my glasses on because everything's just like a little bit blurry right now. She was coming in, she'd been diagnosed with breast cancer when she was 66. You can see here her sister was diagnosed with papillary thyroid cancer at 61. Her brother was diagnosed with prostate cancer at 65. It says intermediate up there. So intermediate risk as opposed to high risk. This wasn't metastatic. Heather mentioned earlier, more aggressive prostate cancer. There's a little bit higher of a chance of that being genetic. So this was intermediate risk. He also had a sarcoma diagnosed at 19. Sometimes sarcomas sort of get the ticket to see genetic counseling because they're on the rare side and they might be more associated with a genetic mutation. His particular kind of sarcoma wasn't. But other family history of cancer, dad with lung cancer, paternal grandmother with liver cancer, and then a paternal first cousin with ovarian cancer diagnosed and passed away in her late 60s. And then on her mom's side, mom had basal cell carcinoma, skin cancer. Maternal uncle had melanoma in his 60s and passed away from that. And then maternal grandmother had bilateral breast cancer diagnosed in her late 70s and she passed away at 89. So evaluating this overall, like Heather said earlier, about 1 in 3 people will develop a cancer in their lifetime. So I want to know, are more people in this family diagnosed than 1 in 3? I would say looking at it from a bird's eye perspective, no, although it's interesting that she and her 2 siblings were all diagnosed with a cancer. And then we're looking for clusters of either the same type of cancer or genetically related cancers. And again, breast, prostate, ovarian can all go together. So that stands out from this particular family history. And then I'm also going through with the patient to say, papillary thyroid cancer, yeah, that can be seen in different genetic conditions, but many people do have thyroid cancer, so I'm not particularly worried about that one. One person in the family with lung cancer, I might ask them, did that person have a history of cigarette use or any kind of history of exposure? We know of at least one gene that's related to hereditary lung cancer, but if I'm thinking about that gene, I'm thinking about lung cancer that's diagnosed at a young age. And again, multiple people in the family diagnosed with lung cancer. A liver cancer at 65, again, that doesn't really stand out to me as being something that's something that really is striking for being genetic. Basal cell carcinoma, many people develop that. Melanoma, same thing. Biggest risk factor for skin cancer is the fairness of our skin. So really we're left with bilateral breast cancer, maternal grandmother, breast cancer in the patient, prostate cancer in her brother, and paternal first cousin with ovarian cancer. So she met criteria. I would say I'm not particularly suspicious that we're going to get back a positive result, but that was how we went into testing. She was interested. Does anybody want to guess what her results were? They were negative, uncertain. Negative. She was negative. And then the question is this reassuring for other people in her family? And I would say that it is. She doesn't have any children, but if she did, I would say there's no reason for them to be having any different screening. And there was no reason to think that this patient was at an increased risk for any other type of cancer. So this was good news for her. Any questions about this example? Yes.
No, I work with you, but I just wanted to say that, do you find that sometimes when people are giving you the program, the person that you're interviewing, and they're saying things like, oh, my sister had ovarian, and they're really meaning cervical? Do you know what I mean? Like,
Yes.
I guess the history collecting is the.
If a patient says, my sister had ovarian cancer in her 30s and she's now in her 60s, I'm like, wow, she was really young when she had ovarian cancer. Do you think there's any chance that might have been cervical? There are some signs that I try and pick up on, like age and how aggressive it is, because usually ovarian cancer is more aggressive. Other questions about this example? So here's a second example. This man was coming in, he was diagnosed with prostate cancer at 55. He had a pretty striking history, family history for prostate cancer. So his brother was diagnosed with prostate cancer at 51. His dad was diagnosed with prostate cancer at 80. uncle passed away with prostate cancer at 70. Paternal first cousin passed away from metastatic prostate cancer in his 50s, and then paternal grandfather with prostate cancer passed away at 67. Just like a lot of prostate cancer in the family. I think we could certainly say more than we would expect, at least on dad's side of the family, where it seems like every male pretty much had prostate cancer. Anyone want to guess what his testing was, positive or negative? He was also negative, which was surprising to me. And then the question is, what do we do with that result? Is that good news for him? Is that reassuring for his sons? I would say no. What this means is that we just can't explain why he and his family members have a history of prostate cancer. It could mean that, again, it's a technology limitation and there's some genetic mutation in his family that we can't find. That's definitely possible. Most of our testing is looking at really significant increases in cancer risk. So gene mutations that would increase risk by a factor of 2 or 3 or 4. But we know that in families, sometimes there are factors, genetic factors that are increasing risk by 1.5 or 1.4 or 1.3. And a family could have 10 of those factors, and our testing just isn't looking for those or reporting those. So that could be what's going on here. It could also be that maybe someone in his family had some mutation that he didn't inherit, and he just happened to get prostate cancer. It's hard to say. But I would say for his sons, who are both in their 30s, they should at least be having prostate cancer screening earlier. Our guidelines say that they should start having screening by the time that they're 40 and just continue to regularly do that, annually. And then testing could improve in the next few years, and maybe we could invite this patient back in for testing to see if we find anything. Questions about this example? Surprising though. So not reassuring. And then this is the last patient example that I have. This was a woman coming in. She's 52 years old. She'd been diagnosed with breast cancer at 50, so a couple of years before. She didn't have a lot of information about her family history. They were kind of estranged. She'd had kind of a rough childhood and just got out as soon as she could. So just had vague information about both sides of the family, but knew that her uncle had been diagnosed with colon cancer at some point and passed away in his 60s, and then thought maybe her paternal grandmother might have had breast cancer at some point in her life, but really wasn't sure. So if I'm going through kind of what I talked about earlier, do more than 1 in 3 people have cancer in this family? No, but it sounds like we're limited based on the information that's available to the patient. We're not necessarily seeing clusters of the same type of cancer or genetically related cancers necessarily, but again, limited information. So this patient met criteria based on the fact that she was diagnosed with breast cancer at 50 alone. Our criteria says anybody diagnosed at 50 or younger meets criteria regardless of their family history. And this patient had actually requested to be referred. Testing wasn't offered to her initially, and our guidelines have been updated relatively recently, so she may not have met criteria when she was first diagnosed. But she was definitely eager to have testing, particularly for her granddaughters. Any guess as to whether this patient tested positive or negative? Positive. She was positive. She had a mutation in what's called the ATM gene. The risks are a little bit lower than in the BRCA gene, but mutations in this gene are related to an increased risk of breast, ovarian, and pancreatic cancer. So this was a real win for self-advocacy and for the patient coming in to see me, and she felt so relieved that she had undergone testing and had this information for her family members. Risk of breast cancer is somewhere around 20 to 30%, and then we can talk about high-risk breast screening. Ovarian cancer is much lower risk, somewhere around 2 to 3%, and pancreatic cancer 5 to 10%. So again, she was relieved to have this information. A lot of patients ask, well, how do I communicate this to my family members? How do I tell them this bad news that I potentially have given this to them? And I tell them that we've just put a label on something that you've had your whole life. We've just named it. It was already there. Now we can do something about it. And potentially, you know, your kids or your grandkids test negative, but at least we can know this information so we can do something about it.
Question. What they were noticing at Hope Abounds over the last 5 years is the increase of breast cancer in males.
Mhm.
You mentioned granddaughters.
Mhm.
How does that, what is the risk with grandsons at this point?
For our different genes, there's different guidance on whether we're seeing an increased risk of male breast cancer. For ATM, I don't believe we've seen that correlation. A lot of, when I hear breast cancer in a male in family history, a lot of my patients are saying, well, his dad had exposure to Agent Orange or something. It was in the Vietnam War, but I'm not sure why that's on the rise. I haven't heard much about that. That's a good question. Think about. Yes.
When, like, through these like patient histories, you're talking about like when cancer was diagnosed. Is there a point like for people living longer that matters less? Like you have a bunch of people in your family that all reach the age like 70s and then they're getting cancer diagnoses. Where's that balance between like older age diagnosis and like younger age for prevalence and importance of it?
Yeah, it's a great question. Our criteria includes both the ages of diagnosis, so is it younger or is it not, and how many people in the family have this genetically related cancer. So I agree. I think urologists say if men all lived long enough, they'd all get prostate cancer. And we're not gonna find a genetic mutation in all of them. So at some point, our criteria will have to adapt for people's lifespans. But for now, it's focused on like, you know, if 3 or more people in a family have prostate cancer, then we should do testing for them. Other questions based on this result? Okay. So how can patients get to me? Many are referred by their primary care physician or an OBGYN or other specialist. But I have patients all the time just call me and want to come see me and figure out if they meet criteria for testing. So a referral is not required. This is my office number on the screen. If anyone would like to take a picture of it, you are welcome to call me and we can have a conversation at any point. Always, I do screening over the phone. So I want to understand if you're calling in, what is your concern about your personal or your family history? That way we can have similar expectations. Sorry. Oh, that was a fun sound. If I know that a patient isn't going to meet, if I know that a patient isn't gonna meet criteria for testing, I'll tell them that over the phone, just so that they know you may have to pay the self-pay price for testing, which is often $250. So if a patient feels super comfortable with that cost and they know they're not gonna meet criteria, then I say, we'll bring you in and we'll have an appointment and we'll figure out what kind of testing to offer. If a patient's like, oh, I'm reassured by the fact I don't meet criteria and I definitely don't have $250 to spend, we'll talk to them about financial assistance resources that are available to our labs. But I would say also like, it's okay if you don't want to come in for this appointment. So at least they kind of know that information. But that's all the information that I have. I was told that no presentation is complete without a picture of the pets. So here's Milo and Kirby. But thank you all for listening and I'm happy to take any additional questions. Yeah.
How would you handle a patient that has not been diagnosed with cancer but doesn't have any sort of extensive family history but have concerns?
So I guess it would be like, why does the patient have those concerns? And sometimes it happens, I think, with patients who are adopted. They truly have no family history and then they just want to know. That is a piece of information I can give to labs and to insurance companies to say like, hey, this patient is adopted. They just want to know. I don't know what the likelihood is of insurance covering that testing, and I would tell them about the $250 self-pay price as well. And then, of course, all the financial assistance options that are available. Other questions?
So, I'm thinking of that second example, the family history of the prostate
Yeah.
cancer. You mentioned like potentially in the future as technology gets more developed, like, they could come back.
Mhm.
Is that like an initiative you guys are trying to do of like almost building a database, or is it still up to someone to just like keep coming back, or is, right, so like they wouldn't have to necessarily go through their insurance and go through all those things, but
Yeah.
like potentially with life insurance, if they were part of almost like a clinical study,
Mhm.
like, is that a possibility? Is that something?
It's sort of an in-between. I would say like if patients are super gung-ho about figuring out why they have so much history in their family, check in every few years and we'll see if we have more genes that we know about or new testing. We now have RNA testing on the market. So we used to just have DNA and now there's RNA. So there was a conversation about should we be contacting patients with really suspicious histories to say, hey, there is more testing available for you. And that is something that's starting at Novant. Yeah, thank you.
If I'm genetically predisposed for say prostate cancer, is there something that I can do, maybe lifestyle choices that I can make to reduce my risk of that?
I always tell people that it's what your doctor is probably already telling you. So exercise regularly and eat a high fiber diet and eat well. And we know that people who do all those things still end up with a cancer. So we could walk through some of the data that's available on lifestyle changes. And ultimately, it is helpful to do all those things, and luck or risk is just a big component.
You see this in the future becoming just a standard procedure?
To do genetic testing for everybody.
Like, I was just wondering why is there not the push for that? And like, we do breast cancer screenings, we do, you have to do all that. Why would this not be just done?
Yeah, I think we're certainly moving toward that, or at least offering testing to everybody. Let's say everybody with breast cancer or everybody with prostate cancer. We do not have enough genetic professionals to field doing all the testing and having a conversation about what those results mean for them and their families. So we're getting there, but we
But you
just
see
don't
that
have.
maybe moving to that?
Yeah, I think we're definitely moving to that. So we follow, and most genetic counselors follow, the National Comprehensive Cancer Network, NCCN criteria. But recently, the American Society of Breast Surgeons has already said, just test everybody who has breast cancer. Some patients are adopted, some patients are from a family where they just don't share their family history or health conditions. So we are moving there. Other questions? So we have a handy dandy clipboard in front of everybody with a family history tool. It should be pretty self-explanatory to walk through. But we are trying to screen everybody to see, do you meet our genetic testing criteria? And I recognize that some of you may not have all this information, so feel free to message your family members or take this home with you and talk with your parents or relatives, whoever, to see if any of this is in your family. But you can see a list of different items. So the first one on here says, have you or any of your relatives been tested for hereditary cancer? So HBOC, hereditary breast or ovarian cancer syndrome, or Lynch syndrome. Like I said, there's also 70 different genes related to hereditary cancer. So there may be something else in the family, some hereditary risk for kidney cancer that we didn't talk about or something. So any genetic testing, have you ever been diagnosed with any type of cancer? And then you'll get into items where either it could have affected you or your family members. So the first one is breast cancer at age 50 or younger. You can check for yourself. You can check for a first degree relative. That would be a child, a parent, a sibling, a second degree relative. So that would be like a half sibling, a grandparent, a grandchild, an aunt or an uncle. And then third degree relative, a cousin, a great grandparent, a great aunt or uncle, something like that. So if y'all will help us and help yourselves by filling out all this information, we can walk around and make sure that there are no questions in case, but we'll let you get to it and fill this out.
Can we also give Katie a round of applause?